Good morning, everyone. Today I will be discussing an important and clinically relevant topic: why winter and cold exposure significantly increase the risk of acute myocardial infarction. Seasonal variation in cardiovascular events is well documented, with a consistent rise in acute coronary syndromes during winter months across geographic regions. In this talk, I will explain the pathophysiological mechanisms by which cold exposure acts as a cardiovascular stressor, precipitating plaque rupture, thrombosis, and myocardial ischemia, particularly in vulnerable populations. This discussion is intended for medical professionals, and we will focus on mechanistic insights, clinical triggers, and implications for practice. Large population studies demonstrate higher incidence of STEMI and NSTEMI in winter, increased early morning MI events, higher short-term mortality during cold spells. Um, Even modest reductions in ambient temperature are associated with a measurable increase in MI risk, suggesting that cold exposure itself, rather than behavioral factors alone, is a major trigger. Cold exposure activates thermoregulatory mechanisms um, aimed at preserving core body temperature. This is mediated primarily through sympathetic nervous system activation, alpha adrenergic vasoconstriction. The physiological consequences include increased systemic vascular resistance, elevated systolic and diastolic blood pressure, increased left ventricular afterload. From a cardiac standpoint, this leads to increased myocardial oxygen demand, reduced coronary perfusion pressure distal to fixed stenoses. In patients with established coronary artery disease, this supply-demand mismatch can precipitate ischemia and contribute to type 2 myocardial infarction or act as a trigger for plaque rupture. Cold stress results in sustained sympathoadrenal activation. This leads to elevated circulating catecholamines, increased heart rate and blood pressure variability, reduced heart rate variability. Clinically, this autonomic imbalance increases myocardial oxygen consumption, promotes coronary vasoconstriction and vasospasm, increases susceptibility to ventricular arrhythmias during ischemia. This mechanism is particularly relevant in smokers, patients with endothelial dysfunction, patients with variant or microvascular angina. Winter months are associated with a prothrombotic hematologic profile. Observed changes include increased platelet count and platelet aggregability, elevated plasma fibrinogen levels, increased factor VII and von Willebrand factor, increased blood viscosity due to hemoconcentration. These changes collectively enhance thrombus formation at sites of plaque disruption, increase the likelihood of occlusive coronary thrombosis. This explains the higher proportion of ST elevation myocardial infarctions observed during colder months. Cold exposure adversely affects endothelial function. Mechanisms include reduced nitric oxide bioavailability, increased oxidative stress, heightened inflammatory signaling, seasonal increases in C reactive protein, interleukin 6. Other inflammatory mediators promote endothelial activation, increased shear stress at plaque shoulders, destabilization of thin cap fibroatheromas. This environment favors type 1 1 myocardial infarction due to plaque rupture and thrombosis. Winter is associated with higher 24-hour mean blood pressure, exaggerated morning blood pressure surge, increased prevalence of non-dipping or reverse dipping patterns. These hemodynamic changes coincide with peak sympathetic activity, increase mechanical stress on coronary plaques, explain the higher incidence of early morning myocardial infarction. This is especially relevant in patients with uncontrolled hypertension, chronic kidney disease, autonomic dysfunction. Acute, unaccustomed physical exertion in cold conditions represents a classic trigger for myocardial infarction, and examples include snow shoveling, heavy lifting, sudden brisk walking in cold air.
Pathophysiologically, this results in abrupt rise in heart rate and blood pressure, increased catecholamine release, marked increase in coronary shear stress. This combination is particularly potent in triggering plaque rupture in susceptible individuals. Winter is associated with increased incidence of influenza, pneumonia, viral respiratory infections.